We're going to be moving from these very eloquent, minimally invasive procedures to something a little bit more maximally invasive here now too. But I do think you'll see that the full-length midurethral slings, the retropubic slings, and the pubovaginal slings still have a role in female urology for sure. I have no relevant disclosures. So retropubic slings, really they are what's considered to be the gold standard in the AUA guidelines. They're familiar to most urologists and patients as well. Everybody's heard of the meshes now as far as our female patient population is concerned. That's usually what they're talking about. It's widely taught and widely adopted, and a lot of people can come out of training very well versed in how to do these procedures. Really, it's called the midurethral sling because its position is exactly there. It's going to go right in the middle of the urethra. And it has a long history. It's again, it was FDA approved in 1998, and the SUI guidelines. Again, it's probably the most widely studied anti-incontinence procedure that has 15-year data, which we'll show in a second here. But very high subjective and objective cure rates, as previously mentioned. And retropubic slings in the AUA guidelines also provided the bulk of the data in their analysis. So long-term, again, they looked at actually the original TVT cohort out of Europe, and they followed them all past 15 years. And they still had a 91% objective cure rate and an 87% subjective cure rate in that original initial population. So again, very good duration of effect. So it's one of the things we were concerned about with some of these other therapies is that they don't have the long-term data. Well, this does. So again, I think what I really want to focus on here is just getting this technique right, because again, this can be a very dangerous and scary procedure sometimes. Transoperator sling, for example, was actually really created to avoid getting into that retropubic space. But really, if you adhere to your landmarks and you're very careful about these things, you can really do a nice job with this. So the midurethra is really what we're going to focus on here. And I always mark my patients just like this, really, in the beginning. I kind of go about 1 centimeter from the meatus. I mark the bladder neck, and then I kind of find where the urethra is going to be, pretty much best supported in the middle, and I center my incision over that area right there. A dissection, I think, is one of the most key parts. In fact, this is the part I teach my residents last. They can do the needle passage right away, but you have to get down to the right depth, and you want to get lateral enough that you can easily get your finger underneath the pubic ramus on either side. And that's really for any of these sling techniques, and so I think it's important to adhere to that. Whether or not you want to hydrodissect first or not is up to you, but I actually do choose to do that. I feel like it makes the plate a little bit more obvious. Suprapubic incisions here, placed as so. And then really, when you're passing the needles, you want to really make sure that that needle goes just above and behind the pubic bone, and then really kind of just thread it right down into that retrovesical space, making sure that you drain the bladder first. And then you want to come out on your finger under guidance. Another important thing is you don't want to arc the needle up towards the bladder. You really want to get it pointed back towards you a little bit. That's a really good way to avoid getting into the bladder. And I think most of the mistakes that we'll see, and as Jason mentioned, you have residents that will perforate the bladder for you very readily. If you can get them to not aim the needle towards the head or the bladder, you're going to really avoid most of these perforations. Sling is then deployed. I like to use a Hagar dilator to place a space between the sling and the urethra. I think it's important that there's a visible gap there. You don't want these slings in too tight. They probably do condense or contract a little bit over time as well, so you have to account for that going forward. Roger Demikowski was my mentor, and he always said, you can almost never put these in too loose. It's just really providing a backboard or support. TVT, the original one, this is a bottom-up approach here just to show that. Again, really the same vaginal dissection, it's just that you're introducing the needle from a different direction. Outcomes are similar, so I'm not going to belabor that. Successful placement, you can actually see these things on ultrasound pretty well. So this, I don't know if that projects really nicely up here, but if there's the urethra, the mesh is sitting right there. And actually ultrasound's a really good way to diagnose a misplaced sling if you're ever concerned about that as well. Autologous slings, on the other hand, so this is really the oldest, and again, we're kind of working up in the maximally invasiveness scale of things here as well. It's really been around for 50 plus years, and it never really had any head-to-head trials because in the original iterations of it, but it's been very effective in numerous studies, and you can use rectus fascia or fascia lata. Rectus fascia is much easier to obtain, of course, because you're going to be in the retropubic space anyways. Fascia lata is probably a nicer graft to work with, but there's a trade-off, of course. You have an increased invasiveness and increased morbidity compared to midurethral slings. And, these are fallen out of favor largely in favor of the mesh slings, rightfully so, because the mesh slings are just as effective with fewer side effects, fewer complications, and lower recovery. So why are we even talking about autologous slings anymore? Well, they still do come into play. I mean, you have people who just will outright refuse mesh, but really probably do need some kind of a sling over, say, a bulking or even a single incision sling. I think the secondary procedures, which we'll talk about here later a little bit, really lend itself well to using autologous sling, really when you're on your last steps for these patients sometimes. All right. Technique, again, you want to make sure that you do a good urethrolysis on these patients, actually. So I always approach this through an inverted U. You don't have to go that way on the vaginal wall. You want to perforate through the endopelvic fascia and actually get your finger up in photo B here on the upper right. So you're almost touching the backside of the rectus fascia. And I always love having students and residents feel this area too, because it's really not a place that they're going to stick their hand over too often. And then bring the sling needles on over there. Again, I use usually rectus fascia for this, about a 10 centimeter by 2 centimeter harvest. Close the primary defect there first, and then fashion your sling with some kind of a suture to pass it. In my case, I use Proline, but you can probably use even a delayed absorbable if you want, because as long as the sling spans the space between the endopelvic fascia, it will heal into place very nicely. This is just depicting how we withdraw the sling into position, and then when you tie the sling down, you really want to make sure that you tie this loosely as well too. Now if you use the Perea passers, you're going to have 2 strands on each side, and you can tie those over some kind of a spacer or an instrument. I use Stamy needles for my needles, and I just tie both strands across the midline to each other, making sure that I can get 2 fingers underneath the tied suture very easily. So that's the looseness. And again, what Roger Demikowski always told me is, again, you can't put these things in too loosely. So it's pretty reassuring to know that, as long as you don't objectively or, intentionally try to obstruct them, they're going to do fine. Again, final position at the bladder neck here, whereas the midurethral slings, again, are more in the middle of the urethra. So I wanted to talk briefly about non-index patients populations. For the midurethral sling, mixed incontinence patients is what the experience is out there. And then for pubovaginal slings as a secondary procedure, because we're not really going to use this as a primary incontinence treatment anymore. It's going to be more adjunctive, especially after post-mesh removal, or if you're doing a urethral diverticulectomy or some other kind of vaginal reconstruction. This is actually a very good fistula repairs, things like that too. It's a very good interposition layer too. Mixed incontinence, again, no secret what that is. It's a combination of urge and stress in any severity. Frequently the two are seen together, so I think a lot of my patients are actually mixed incontinence to begin with. The best theory is that probably if you can't close the urethra tightly, urine gets into the urethra during stress maneuvers. Even if they don't leak, it probably sets off a bladder contraction, which then gives them that sense of urgency or even results in urge incontinence. And it makes sense. So I would probably treat the stress first in these patients. And a lot of times, patients don't like adhering to medications. But if you remove the underlying cause, if they really do have this true stress-induced urgency, you probably will remove both problems for the patients in a large percentage. And we'll go into that in a second. This, again, is most studied with the midurethral sling. So how do we study this? It's really hard to randomize people. They've tried actually getting a clinical trial for mixed incontinence, and they couldn't complete enrollment because of the large number of patients and just the disparity between the two groups. But a lot of times you'll have secondary outcomes as far as urgency and things like that in the midurethral sling trials as well. So the data says patient satisfaction is going to be lower if the urge is persistent. Informed consent is crucial after slings, and so you just want to make sure that you discuss this with the patient, that they still may have persistence of their urgency if they have mixed symptoms. Cure rates are variable here. I'm trying to move through here quick so we don't go too over time, but the urgency did resolve anywhere between 30 and 85% of the time. Severity probably does matter. If you have demonstrable overactivity on urodynamics, they're probably going to have worse outcomes, and if the urgency symptoms are greater than stress, they're probably going to have worse outcomes as well too. We reviewed our patients for this. This was presented at the Western section, 8 years ago now, but we had 111 patients with mixed symptoms, followed them with UDI-6 and PGI-S scores. We had 66% resolution of the urgency in mixed incontinence patients, so I think that's a pretty good number to hang your hat on, is at 65 to 70%, or roughly 2/3 of patients. Secondary autologous slings, again, not really any prospective trials on this. It works both well for both a fixed and a mobile urethra. Patients either need a secondary procedure or they just don't trust any more mesh. Again, you're going to see really good success rates here. Overall success, ranging anywhere from 70 to, even lower percentages. But if you've looked at some other secondary studies, this one's by Petru out of Mayo Jacksonville, they had about, again, 75% success as a secondary procedure. So it's still worth going to, I think, for most patients here. And then again, no difference in cure rates between a primary and secondary autologous sling, so it does seem to hold up its efficacy as an adjunctive procedure without too much drop-off in the effect that you're going to get. So I'll just conclude by, there's a lot of information out there on the internet about slings, and if you ask ChatGPT to show you a midurethral sling in a patient, and I asked them to do it in the spirit of netter anatomy, this is the two images they gave me here. So you can see the mesh or the netting that they talk about. I mean, this is the stuff that patients go into thinking this, and I think ChatGPT is probably just compiling what everybody thinks on the internet of what's going on here too. But I thought the flowers and the vines were interesting of what we would put in the pelvis. So a little fun at the end here, but thank you.